So good afternoon, everyone, or good morning or good evening, wherever you are. We will start this session shortly. We're just waiting for a few more people to enter the room. So in the meantime, if you want to tell people where you're from, just leave a little message in the chat. So we'll start very, very soon. So good afternoon, everyone, and welcome to this EAPC webinar. We're delighted that you've joined us for today, this webinar, which will be presented by the EAPC Task Force on Social Work. The webinar will start soon. We have a lot of people registered to attend today, which is fabulous. So I'm just allowing people a few minutes to all join. Just to let you know, in case you're concerned, that as an attendee, you are not on video and we cannot hear you. You can, however, engage with us by using the chat box. We've decided for this session that the Q&A will be disabled. So whilst you can see the Q&A box, we encourage you to ask any questions of our speaker today using the chat. If you have any technical difficulties at all, please just raise your hand and either myself or my colleague Guillermo will try and help you as best we can. So if you want to start today's session just by using the chat box to tell us where in the world you are joining us from today, that would be super. To let you know as well that the webinar is being recorded, and it will be available on the Social Work Task Force group page within the next week or so. A certificate of attendance is also available for anyone who is joining this live webinar. Towards the end of the webinar, I will post a link to a page where you can complete the webinar evaluation form and download your certificate. So I really encourage you to do that as it's very useful for us to get that feedback from you. Also, do keep an eye on our social media and our webpage for news of future events. And if you are using social media, please do include the hashtag EAPC webinar in your conversations so that we can track this conversation. It's now my great pleasure to hand you over to Stephen, who is from the Task Force for Social Work, who is going to introduce our speaker for today's session. So thank you, Stephen.
Thank you, Kathy. Yes, hello everyone. Welcome to this regular webinar that we host. My name's Steve Marshall. I'm the co-chair of the EAPC Task Force on Social Work. Unfortunately, the other co-chair, Audrey Ralston, can't be with us today because she's teaching, but she and I will really appreciate everybody coming along. It's my pleasure to introduce my colleague, Dr. Joanna Davis, who I actually work with. I work at King's College London and I work with Joanna. What I'm going to do is hand over to Joanna in a second and let her introduce herself. And just to reiterate what Kathy said, I'll be managing the chat as well. And if you have any questions, please pop them in the chat and then we'll have a chance at the end. I will read out the questions and we'll get a response from Joanna. I think, Joe, you're going to talk for about 40 minutes, am I right? So if we could bear with Joe, but put questions in and then I will go back to them after the 40 minutes. So I will now hand you over to Joanna Davis.
Thank you, Steve. Thanks. It's a real pleasure to be here. And thank you to you and Audrey and everybody else involved in the Social Work Task Force for inviting me. So I'm just going to attempt to share my screen and my slides. Bear with me a second while I make that full screen. Can you see that all right, Steve?
Yes.
Great, thank you.
Yeah, it's great.
Okay, So, as Steve said, I'm Joanna Davis. I'm a research fellow at the Cicely Saunders Institute, and I have a background in sociology. That's what my undergrad degree is in. But most of my research is really about social epidemiology and about understanding inequality in palliative and end-of-life care. And a lot of the work that I have done uses big data, routinely collected data, to try to understand and address inequalities. So that's going to be the topic for the talk today. And I just want to acknowledge my funders, the Dunhill Medical Trust and Marie Curie, who have funded various projects that I'm going to talk about today. So let's start with a definition of health inequalities. They're the avoidable, unfair, and systematic differences in health between different groups of people. And I really want to emphasize those words: avoidable, unfair, and systematic. Putting health inequalities right is a matter of social justice. It's about the kind of society that we want to live in. But the evidence really matters. Good intentions are not enough. And that's a quote from Michael Marmot, who many of you will be familiar with and who has done a great deal of work on health inequalities. And the Marmot curve is a really well-known illustration of health inequalities, and I'm sure many of you will have seen it before. It's a graph that has age down the y-axis and then neighbourhood deprivation across the bottom there, and each of those green dots is a neighbourhood in England. And what it shows at the top of the graph with the lighter green scatter, it shows that life expectancy on average in the most deprived areas in England is 7 years lower than life expectancy in the least deprived areas. And that in itself is a really shocking statistic. But even more worryingly, if you look at disability-free life expectancy, which is the darker green scatter towards the bottom of the graph, the gap between the richest and poorest areas is 17 years. So people living in the most deprived areas experience the onset of disability 17 years before those in the very least deprived areas. And Marmot makes several important points about this curve. The first is that it's systematic, and we can see that in the patterning of the dots. There's a statistically significant association there between life expectancy and disability-free life expectancy and the level of deprivation in neighbourhoods. He also points out that this isn't a problem just for the very poorest people in society. The gradient shows that this is a problem for everybody below those at the very top, and that we should seek to bring everybody up to the level of the people living in the least deprived areas. And we need to do that by applying proportionate universalism, by improving health for everybody, but giving proportionately more resources to those at the very bottom of the curve. He also points out that the curve is not inevitable, and we can see that it fluctuates over time. And Marmot has very cautiously but convincingly demonstrated how inequality gets worse in response to austerity policies, for example. So we can see that curve shifting and inequalities widening in periods of austerity. But it's also different in different places. So this curve, for example, was wider in the northeast of England and flatter, less unequal in the southwest of England, and also between different countries. So if you look, for example, across Europe, you can see that health inequalities generally are narrower in Nordic countries, which typically have a more equal distribution of wealth and policies centred on universalism. So he's making the point that it really isn't inevitable, and we can see that in the changes. And when we think about what causes this inequality in health, a large body of work has developed to show that the more favoured people are socially and economically, the better their health. And that's because health is really closely linked to the conditions in which people are born, grow, live, work, and age. This is the WHO model of causation of the social determinants of health, and it presents these two interrelated spheres, the structural determinants or the contextual determinants, which operate on our health through more intermediary determinants, our material circumstances, behavioural and psychosocial factors. And you can see the health system there situated with the potential to mitigate some of those intermediary determinants of health. And these factors that are caused by the unequal distribution of power, money, and resources operate on people across their life course. When we think about the life course, we can think about the accumulation of risks across somebody's life, but also about these critical stages in early childhood, prenatal as well, and how events in those critical periods can have long-reaching consequences for our health. But I'd like to echo Libby Salno and others who have pointed out a really important omission from this figure, which is often used to talk about the life course. And that's that death is missing from this diagram. In this diagram, life seems to end at retirement, but we know that life doesn't end at retirement, it ends at death, and that death also can have far-reaching consequences, particularly for those who have cared for relatives. And the impact that that has on things like employment and their own later life health, but also on other parts of life, you know, for example, thinking about children who might have experienced bereavement. And really that's been a gap that we've seen in lots of the literature on the social determinants of health, that information about how social determinants impact death and dying has really been missing from those national and international conversations. And yet we know there is quite a lot of evidence. We've been quite good in palliative and end-of-life care at measuring the problem of inequality. Those very first studies that Irene Higginson carried out were actually done now 30 years ago, demonstrating that association between living in a more deprived area and being more likely to die in hospital compared to home. So one of the first things that I wanted to do as part of my PhD a few years ago was to bring together all of that international evidence and do a systematic review. Do a systematic review, bringing together that evidence on inequalities in palliative and end-of-life care. So we included 112 international studies, and we found consistent evidence that in high-income countries, people with low socioeconomic position are more likely to die in hospital. They have more hospital admissions in the last months of life, and they're less likely to receive specialist palliative care. And in relation to death in hospital and not receiving specialist palliative care, we were able to demonstrate this dose-response relationship, combining data from different studies to show that for each increase in the level of area-based deprivation, there's an increase in the odds of these outcomes. What we also found was that the literature was dominated by studies on place of death and by studies that use routinely collected data. Studies of that type are really useful for understanding inequalities or differences between groups, but they're less good for understanding inequity, whether those differences are fair or unfair. And for that, to really understand inequity, we need different types of data and we need different types of studies that give us more information about how things like preferences and experiences impact outcomes. So there's a growing focus on palliative and end-of-life care on equity. But much of the research that has happened so far has been dominated by this tendency to carry out studies that are measuring inequality. And arguably, there's been a lack of commitment to action, to critical research, and to acknowledging the structural causes of this inequality. There's also a need to acknowledge the racism and classism that exists in palliative and end-of-life care, and some of these papers have touched on those issues. And we need to begin to take a more intersectional approach in our research to understand how things like ethnicity and deprivation interact and combine. So really, the equity focus in palliative and end-of-life care is in its infancy, and it tends to sit as a kind of discrete research theme, and we need to shift that focus to a theme that runs throughout all of the research we do, and recognise that in the development of policies and interventions, we need to bring equity into focus, because without considering equity issues, we risk worsening or widening inequalities. And we can see that in relation to, for example, the promotion of choice in palliative and end-of-life care and in healthcare more generally. And when choice is promoted without an awareness that choice is not equal for everybody, that choice is often limited and framed by people's circumstances, that choice can actually make outcomes more inequitable. So there's a really important growing body of research doing in-depth qualitative studies, trying to understand the experiences of marginalised groups in society. And I'm just indicating a few of those studies on the screen there. So within this kind of growing equity agenda, what is the role for big data studies, the kind of research that we've tended to do? I would say there's still a really important role for measuring inequality, and push back slightly on some of that commentary around this preoccupation with measurement. Measuring inequality is really important, and even for some of our most well-described outcomes like place of death, there are huge gaps in our knowledge. For example, how inequality in place of death has changed over time or varies between areas, or the causes of that inequality. So I want to spend the second half of my presentation talking about research that we have done using big data to try to move forward this equity agenda and offer insight into the causes of inequality and how to address it. So the first study I want to talk about is a study about place of death that we recently published in SSM Population Health. And we've had a lot of studies about place of death and that have consistently shown this association between deprivation. If you live in a more deprived area, you're more likely to die in hospital. But we've had very few studies and no empirical work really looking at the reasons, the causes of this inequality. So one way to look at this is by using moderators and mediators to understand for who this inequality exists. Does it exist for all groups in society? And then to look at possible explanatory pathways. So why does this inequality exist? So for this study, we used a data set called the ONS longitudinal study. So this is a data set that's been set up for research purposes in the UK, and it takes census data and links a 1% sample of the population who complete the census in England and Wales, and it links them over subsequent years of censuses, and it also links to vital events data, so information on births, deaths, and marriages. So for our study, we were interested in people who had completed the census in 2011 within this 1% sample. And we also wanted to link to their death record. So for the first part of the analysis, where we were interested in moderators, we have our exposure, which is area-based income deprivation, and our outcome, death in hospital versus home, hospice, and care home. And we were interested in how these factors might change that relationship, or how that association might look differently for different groups depending on their age, their sex, their ethnicity, their underlying cause of death, and their region of residence. So we had a sample of just over 34,000 people, so not huge, but big enough to do this kind of analysis. And we were looking at people who had died following completing the 2011 census up to the most recent deaths available to us in 2017. So this is the very familiar association between area-based deprivation and place of death that we're familiar with from lots of other studies. And it shows that if you live in a more deprived area, you're more likely to die in hospital. And it's not a perfectly linear association. We see that in lots of studies as well. But if you live in quintile 1 or 2, those are the two most deprived quintiles, about 52% of people die in hospital, and compare that to quintile 5, the least deprived quintile, where about 47% of people die in hospital. So that's the association in the overall sample. Now, of all of the moderators that we tested, age, sex, ethnicity, underlying cause of death, and region of residence, we found that underlying cause of death had a significant interaction in this association. So the gradient that we see for cancer, for dementia, and for other causes, and you can see those towards the bottom of the graph, that social gradient that we see for those groups, we do not observe that for people who died from cardiovascular, from respiratory, and from sudden causes. And you can see those lines towards the top of the graph are much flatter. So for the next part of this study, we wanted to ask, why do we see this gradient? So it makes sense to focus on groups where we do actually see that gradient. So there's no point in asking, why do we see inequality for groups where there is no inequality observed? So the moderation analysis was really important for that first step in understanding which groups should we ask that question in. So for the next part of the analysis, where we were looking at mediators, we focused on cancer, people who died from cancer only. And that's because they were the largest of those three groups and a relatively more homogeneous group in terms of their underlying cause of death. So in a mediator analysis, we are interested in the relationship between the exposure and the outcome. Now, normally when we do a regression analysis, we're interested in how confounders, factors that are associated with both the exposure and the outcome, might muddy the waters or change the association between the exposure and the outcome. In a mediation analysis, it's a bit different, and we're interested in factors that sit on the causal pathway from the exposure to the outcome. So the exposure causes the mediator, which in turn causes the outcome. So here is our mediation model. We have our exposure on the left-hand side, which is area-based deprivation, and our outcome on the right-hand side, which is death in hospital versus home. And then our theoretical mediators in the middle. So we wanted to test pathways through living alone, housing deprivation, and worse, self-rated health. And these are really based on existing literature, which tells us that people who live in more deprived areas are more likely to live alone, more likely to live with housing deprivation, and have worse health. And so we wanted to test whether these factors could potentially explain that relationship that we've seen between deprivation and death in hospital. So what we found was that area-based deprivation was associated with these factors in the way that we expected. So people who lived in more deprived areas were more likely to live alone, they were more likely to live with housing deprivation, and they were more likely to have worse self-rated health. And we found that living alone did predict death in hospital. So people who lived alone were more likely to die in hospital. And when you include that in the mediation model, that relationship explains about 12% of the total effect of deprivation on death in hospital. We found that people who had worse health were less likely to die in hospital. And that once you had accounted for the fact that people who live in more deprived areas have worse health, the effect of deprivation was actually strengthened. So that's a type of effect called a suppressor effect, where the inclusion of the variable actually strengthens the effect of the exposure. And I think we can think about why that might be the case and how it might be different for different groups. And this is a sample of people who died from cancer. So potentially those who had worse health overall may have had a more predictable prognosis and might have had more time for planning and for planning their care at home. So that could be one explanation for why we see that relationship. And in our model, housing deprivation was not associated with death in hospital. So some take-home messages from that work. The social gradient in place of death depends on cause of death, and that's been really important for thinking about potential interventions that might address inequality in place of death and where we might target those interventions. People who live in more deprived areas are more likely to live alone. And for people who die from cancer, this partly explains why they're more likely to die in hospital, again, indicating a potential way to reduce inequalities by supporting people who live alone in more deprived areas. And this effect of this potentially bidirectional effect of worse health is also really important for thinking about how we might understand that relationship between deprivation and health and how we can adjust for health in different models. But there are lots of caveats and limitations with this type of research. So, for example, that finding that housing deprivation was not associated with death in hospital is potentially limited by the way we measured housing deprivation. It might not capture all of the aspects of housing deprivation that are important to that relationship. And there are other limitations too. For example, in the moderation analysis, we found that ethnicity, for example, did not moderate the relationship between deprivation and place of death. Although we had a reasonably large sample of just over 34,000 people, that's still quite small when you start to break it down into the different subgroups. So potentially the way that we grouped ethnicity or regions as well, looking at those large regions, it's likely to mask lots of variation within those groups. So repeating this kind of analysis in bigger data sets, we had a 1% sample of the population, but this work could be repeated for the whole population and offer different insights. So really, this is a kind of first step demonstrating how this kind of research could be used to understand more and offer a more in-depth insight into inequalities. So the second thing that I want to talk about is intersectionality. And this is really the idea that we're never just one thing. People are a representation of lots of different aspects. And Audre Lorde was one of the first activists to really talk about intersectionality. So we have that nice quote from her there. There's no such thing as a single issue struggle because we don't live single issue lives. So we've been really interested about how we can try to take a more intersectional lens. There's a real tendency, probably more in quantitative research, but in qualitative research as well, to look at single risk factors or to focus on one risk factor above others and suggesting that that's the more important thing to focus on. So a real challenge for us has been how we can use data to take a more intersectional lens. And very large data sets have a really useful application in understanding intersectionality, because they can allow us to look at those subgroups in large enough numbers to give us meaningful results. So the second study that I want to talk about is the study that we did using data for the whole of England in 2019 and 2020. And we accessed that data through the British Heart Foundation Trusted Research Environment, which is one of the largest trusted research environments for NHS England. And this is work that we did for part of a series of reports called the Better End of Life Project, funded by Marie Curie, to look at the palliative care response to the COVID-19 pandemic. So we started with mortality records for all deaths in 2019 and 2020. And to that, we linked in data from primary care, so from GP records. And in particular, we really wanted to use that data to pull the better quality ethnicity data that exists in primary care data. Ethnicity data in hospital records in the UK is often incomplete and thought to be not as good a quality as the records in primary care. So it was really important to bring that data in. And it also allowed us to use data on prescriptions, which we used to estimate comorbidities by looking at the prescriptions that people had in the last year of life. And then we also linked into that hospital episode statistics, allowing us to look at our outcome of ED visits in the last months of life. So the first part of the work is written up in this Better End of Life report alongside other data. And we looked at the picture overall in the last year of life in the 4 nations of the UK. So here we're looking at ED visits in 2020 for all deaths in England, Scotland, Wales and Northern Ireland over the last 12 months of life. And you can see how ED visits increase towards the end of life, and particularly from 3 months before death onwards. And ED visits were really common. So around 60% of people have an ED visit in the last 3 months of life. And we looked separately at visits in hours and out of hours. So out of hours were those visits that were in the evenings, at weekends and on bank holidays. And you can see, particularly for out of hours, there's a really steep increase in the number of visits in the last months of life. And we could see that similar pattern across the 4 nations. And then we also looked at the association between deprivation and ED visits. So again, just looking over the last 12 months of life here, and we're just looking at England, we're looking separately at men and women and for these different age groups. But you can see that consistent social gradient. If you live in a more deprived area, you have more ED visits in the last 12 months of life. And that gradient is perhaps most steep for the youngest age group. So in this paper, we were able to delve into this data in a bit more detail. And one of the things that we particularly wanted to know was whether that gradient that we saw consistently for men and women across different age groups, whether that gradient was consistent for different ethnic groups as well. So here we're looking at the age-adjusted rate of ED visits, and then we're focusing on the last 3 months of life, because that's where we saw the most ED visits over the last year of life. And we're looking at the rate of ED visits for these different groups, and we've got the ethnic groups across the top, and that's shown against deprivation and separately for men and for women. And one of the things that stands out straight away is that particularly Bangladeshi, Pakistani and Indian men have higher rates of ED visits in the last 3 months of life. But what we also found is that that gradient that we see for white British people, where for each increase in deprivation, we see an increase in the number of ED visits, that gradient is there for Black African men, but it's not there for most other groups. So that assumption that the social gradient is ubiquitous, is common across groups, doesn't hold in this data, and that's been really important for us to understand. And the flip side of that is that deprivation therefore can't really explain the higher rates of ED visits in some of these ethnic groups. So to investigate that in a bit more detail, in that paper, we looked at the rate of ED visits for all of the ethnic groups compared to white British people. Again, we did it separately for men and women to try to understand that intersection. And we also separated this analysis looking at visits in hours and out of hours, because we'd seen that slightly different pattern for the out of hours visits. And we wanted to try and understand that in a bit more detail. And we wanted to adjust for different factors to see how far we could explain away some of the ethnicity effects. So the blue bars adjust only for age, the red bars additionally adjust for geography, the green bars additionally adjust for deprivation, and the yellow bars additionally adjust for morbidity. And what you can see straight away is that the inequality looks different in hours and out of hours, and it emerges most strongly in the out of hours period. The inequality isn't there for lots of groups in the in hours ED visits. And what we can also see is that for Bangladeshi, Pakistani, Indian, and other ethnic groups, even after you've adjusted for all of those additional factors, those groups still have higher rates of ED visits compared to white British people. So some of the take-home messages from that work were that the deprivation gradient that we see for white British people is not seen for most other ethnic groups. There's something really important about the out of hours period, and inequalities emerging most strongly in that period. And it also highlighted particularly South Asian groups as a group that are not, homogenous, but separate groups who are often grouped under the South Asian category, but we can usefully disaggregate that group. But those groups are potentially most at risk from higher rates of ED visits. And it raised probably more questions than it answered about how the experiences of those groups, in terms of their preferences, in terms of their prior experiences of healthcare, might be influencing these outcomes. So the final study that I want to talk about is the take-up study. And this is work that's ongoing. It's work that I'm collaborating on with Steve Marshall and Richard Harding and lots of other people. And it really comes off the back of the work that Marie Curie have done on the number of people who are dying in poverty in the UK each year. And this is taken from their updated report from 2024, which showed that 1 in 6 people who die in the UK are dying in poverty, and that's 111,000 people per year. And they use survey data and census data to estimate that number, and you can find the details of that work in that report. Just a note on how poverty is measured. So a lot of the work that I've spoken about so far is about deprivation, and it's about area-based deprivation. And there's overlap between, for example, the number of people who live in poverty in the UK, which is around about 20%, and the people who live in the 20% most deprived areas. There's a lot of overlap between those two groups, but deprivation and poverty are two distinct things that are measured differently. And there are lots of different ways that you can measure poverty. So one is to look at relative poverty, and that's households that earn below 60% of median income for that year, and that allows you to compare between households. You can also look at absolute poverty, and that's a way of looking at how poverty might change over time, and it's related to median income in 2010, 2011 to allow that comparison over time. But the Marie Curie report and lots of other charities advocate for an approach called the Social Metrics Commission poverty measure, which is an approach that looks at households that earn below 60% of the median, but then deducts other inescapable costs related to housing, to childcare and to disability to try to give a more realistic representation of the number of households in poverty. So we know that for people living in poverty, social security benefits are a really important source of income. And in the UK and in some other countries like Australia and America, people in the last year of life or with terminal illnesses can have special fast-tracked access to specific social security benefits that are supposed to mitigate against some of the effects that a terminal illness can have on costs at the end of life, things like increased heating costs, travel costs, the costs of medications and equipment. So to get access to benefits under the special rules in the UK, a doctor or specialist nurse needs to submit a form which gives details of your illness, and that can allow you to have access to benefits without needing to have a medical assessment. So there are lots of reasons why people might not claim the benefits that they're entitled to. People might not be aware, clinicians might not be aware, and there might be a range of reasons why people are deterred from applying for benefits, around stigma, but also around concern about how it might impact their other benefits, for example, if they're already claiming other benefits. So Marie Curie and others have done a lot of work around increasing the financial support available to people in the last year of life. And they have funded us to do a piece of work using big data to understand how many people actually claim these benefits, and are some groups more likely to miss out on these benefits than others. So for this work, we're working with the Office for National Statistics, who are giving us access to a data set that hasn't been used before in research. It's a data set that links up census records to death records, and also to records from the Department for Work and Pensions, who make those benefit payments. And we're looking at deaths between 2018 and 2021. And this is ongoing work, so I don't have any results to show you, but these are some of the things that we're going to be looking at: geographical variation across the country, and whether take-up varies by things like age, sex, underlying cause of death, ethnicity, area-based deprivation, education, English language. And we're particularly focusing on non-means tested benefits. So these are the benefits that are available to everybody, regardless of income or wealth. And the big data work is one component of a wider study that includes qualitative work, doing interviews with patients and carers, focus groups with healthcare professionals, as well as a service evaluation looking at the support around benefit take-up in the community and voluntary sector. And we're bringing together all of these different strands of work to develop resources and training for healthcare professionals aimed at improving benefit take-up. And this really speaks to that point that I made earlier about the need to combine big data research with other types of studies. There's no kind of one way of approaching the question of inequality in palliative and end-of-life care, we need to bring together different types of research. So I'll end here on this slide, which is taking the principles of action published by the World Health Organization in 2008. And I've adapted these because the principles of action didn't mention end of life or terminal illness, but I find these a really useful guide. I think it can be really difficult in palliative and end of life care for thinking about what we can do and how we can take action against the social determinants of health. So this can be a useful guide and a nice slide to finish on. So the first is to improve the conditions of daily life for people with terminal illness. And that's really about looking at all of the policies and all of the interventions and the care that we provide and assessing how equitably we are delivering that care. And that should be a theme that runs throughout all of the work that we're doing. The second point about using our spheres of influence to tackle the structural drivers of inequality. I think we have a responsibility in palliative and end-of-life care to really highlight the impact of health inequalities and how that manifests at the end of life, including in increased costs to society and to the health and social care system. And this third point about evaluating action, expanding the knowledge base, raising public awareness and developing a workforce trained in the social determinants of health. And that's really a core part of what we should be doing in research on social determinants of health in palliative and end-of-life care. So I will end there and really happy to take any questions.
Joe, thank you for that. I've heard you speak before, and I really appreciate, as a jobbing social worker who struggles with numbers, I always appreciate how you manage to make the numbers accessible and understandable for those of us that are perhaps have a more of a qualitative stance. So thanks for that. And there's some really good questions in the chat, which I will start to go through. I just want to say though, we've got lots of colleagues from other European countries, but we also have colleagues from India, from Australia, from Japan, from the USA, Canada, and China and Brazil. So some people have either stayed up very late to hear your talk or have got up very early. So we really appreciate that. So thank you so much for that. I'm going to start with, and I do apologize about my pronunciation of this name, but it's Mijodrag. I think that's how I would say it in my British way. That's probably completely wrong, but they're saying in moderately economically deprived countries, particularly where palliative care has not been fully integrated into the healthcare system, significant challenges persist. Palliative care responsibilities have shifted into the social welfare sector. Social workers bear a substantial professional burden, especially when serving populations in need of palliative care, including highly vulnerable groups such as the poor, the socially isolated, the homeless, and other marginalised communities. They then go on to, there's a second part of this question, I think. Yeah. Furthermore, these groups often lack access to basic rights and even primary healthcare services, let alone specialised palliative care. As social workers, we are deeply committed and frequently required to draw on creativity and resourcefulness to ensure that these individuals are afforded a dignified quality of life and ultimately a death with dignity. So not necessarily a question there, but just, is there anything there that you'd like to comment on?
Yeah, I mean, I think I would absolutely agree with everything that that they were saying in that comment. And one of the studies that we didn't talk about, which you'll be familiar with, Steve, but where we analysed the data on the problems and symptoms that palliative care patients present with in hospital, here at the hospital in King's, where Steve works. And one of the most common problems that patients reported were practical and communication concerns. And those problems not only were common, but were more common for people from more deprived areas. So you can really see in the data the importance of the kind of issues that social workers are dealing with in their patient cohort and how important that is. And I think one of the things that we see here in the UK, and I'd be interested to hear what it's like in other countries, is a real variation in the level of social support, social care support that's social worker support, sorry, that's available in hospitals and in communities. And Steve, you might want to comment on that as well, but it's something that's not available to all teams in hospitals, and certainly not in the community as well. It's very patchy.
Yeah, I just reiterate that. And I mean, I personally feel, certainly I've been a social worker in palliative care for 25, 30 years. And I think the last few years perhaps been the most difficult, really, in terms of trying to get services and support for people. And it does feel like, I mean, in the UK, we're going through a difficult economic period, and I feel like a lot of services that were reliant on the charitable sector, for example, so like Macmillan, which is a big cancer charity, used to give out grants to our patients. That's stopped this year. I mean, and I've been doing Macmillan grants for my whole career. So I totally agree, and I think it's becoming more and more difficult. And I think as social workers, we have to be much more creative. But even as Joe pointed out, even in the UK, so in my team, there's two of us. We have two full-time social workers, but I went up to Bradford recently, which is an area in the north of the UK, very diverse area and also very economically deprived. They don't have a social worker at all in their team, so they don't have anybody in the team that's kind of thinking about how to perhaps support those patients who are more socially deprived just at admission, So did you want to say something, Joe? No?
No, I think that's a really important summary. Yeah.
Thank you for that. We've got a question from Teremes, who says, hello and thank you for the insightful presentation. By the way, there's been loads of thank yous in the comments, so we'll let you have those afterwards, Joe. How do you apply weights when using big data? I must admit, I don't even understand the question.
That's an interesting, very technical question. I mean, it depends on what you're doing. So in a kind of longitudinal study, like the English longitudinal study of aging or the ONS longitudinal study, which I was talking about earlier, there might be reasons why you might want to weight the data so that it's more representative of the general population. But also you have to be quite careful when you start weighting things that you're not kind of muddying the waters and confusing the analysis. So in all of the analysis that I presented today, we haven't used any weights, and sometimes it's that kind of trade-off between just understanding the raw data and needing to kind of adjust things so that it's presenting a more kind of realistic, meaningful approach. And often you need both. You need to kind of look at unadjusted and adjusted, unweighted and weighted. But it's generally a kind of decision that you need to make on a case-by-case basis, I would say.
You've really simplified down what you mean by a weight.
So weight is a way of giving more weight to answers from a particular subset. So for example, if you have a sample where ethnic minority groups or a particular ethnic minority group is underrepresented, there's just a small number of people, you can give more weight to the answers from that group in the analysis so that it's more representative of the general population. So that's one way, probably a simple way of thinking about weights.
Okay, no, thank you. I struggle with quant stuff, so that's great. Thank you, Joe. So we've got a question from Dr. Das. I think Dr. Das has got a couple of questions. It's great to observe from your talk how retrospective data of inequality, poverty, etc., can form policy making process into successive implementation. Great work and very well documented. Thanks for a wonderful presentation. So I think the question is, how can you use retrospective data about inequality to inform policy making?
Yeah, that's a really important question, and this kind of striving for having impact in our research is something that we talk about all the time, Steve, don't we, at work? And it's absolutely what we should be aiming for. I think a lot of the research that I have done, these big kind of routine data studies, they sit very much kind of outside of policy and practice, and they're interesting and they're important, and you need that kind of population level analysis to really understand and to inform and educate people about inequalities. It's really important for that. But how do you take the power of that big data and bring it into the kind of policy setting to help inform commissioning, to help inform the delivery of services? That's much more difficult, and I think requires a much more kind of localized approach. But I think what's also important is the kind of research like the study that we've been working on, Steve, where we are using big data alongside other methods to really bring together those different types of evidence to inform the development of an intervention. In our case, it's the development of training for healthcare professionals to improve benefit take-up. And we're going to use the different parts of that study to really strengthen the development of that training.
Yeah, I mean, I suppose for those of us who working as social workers, it's like, what can we do to identify those people most at risk? Because when you're faced with an individual, you don't know that person's more likely to die in poverty or more likely to die in hospital, or do you know what I mean? I think it's trying to use that big picture stuff, bring it down to when you're faced with somebody in front of you who's dying. Do you see what I mean?
Yeah, and that's what I mean about these population level studies are really important for understanding those risk factors, for knowing, for example, how deprivation or living in a more deprived area might impact somebody's outcomes. And, at the hospital here, that deprivation score is now available, isn't it, in the clinical record? So when you're looking at a patient's clinical record, you get information on the level of deprivation in the area where they live. So I think that's
Not that
one
we
way.
do anything with that, though. By the way, Joe, we don't do anything with it. We know it. I think most clinicians wouldn't understand what that was.
Yeah, and
sorry to interrupt you there, but
no, it's a really good point. And also, when you're looking at a patient's ethnicity on a record, are you really thinking about the intersection between deprivation and ethnicity? But I suppose it's information that is useful to have, and alongside you need all of that knowledge of the kind of intersectional relationship between those risk factors. But yeah, I think there's a gap, isn't there, between what we do in academia and what we do in clinical practice, and we're always trying to kind of bridge that gap and to make the work relevant and impactful, but there's a kind of long way to travel, I think.
Absolutely, thank you for that. A question from, well, it says office, so I'm not quite sure who this is, but it says, many thanks, Joanna. Given that the findings on inequality and inequity involve both quantitative and qualitative measures, how can we synthesize them in a scoping review?
Well, I mean, I think there are definitely methods for synthesizing quantitative and qualitative data in systematic reviews and in scoping reviews. I'm not an expert in that method at all, but it's definitely out there, and I think it would be really interesting to bring together the evidence on inequalities. And I think actually Maddie French has done some work around inequalities on access to specialist palliative care with a particular focus on the UK, and she did exactly that. I think brought together the quant and the qual, and it obviously offers different kind of complementary bits of evidence. So I think is a really important method to do. And when I did my systematic review, it was a definite limitation that I wasn't able to look at the qualitative evidence as well, but you can't do everything, and the aim in that review was to kind of have a broad scope, but there are methods out there. And yeah, I'd encourage you to go and look at probably the Joanna Briggs Institute for some guidance on that.
Thank you. Dr. Daz has another question. It's really good to see how social benefits are interlinked with palliative care settings in your study. I think this is about the take-up study. I'm really impressed, and a lot of take-home messages for necessary dissemination. Thanks. Oh, I'm sorry, it's not actually a question. Another thank you very much, John. Excellent, very useful. That was fascinating, well presented. Oh, there's people from the Philippines as well, Joe. Another question from Arabella. You mentioned the impact of racism in end-of-life care. Could you direct us to any studies that explore this aspect specifically?
Yeah, I mean, there's been a real kind of problem in palliative and end-of-life care of a lack of research into ethnic minorities and into racism. But there's also now lots of fantastic work going on. So I would encourage you to look. Will you be sharing the slides, Steve?
Yes, I think they become available, don't they? I feel like Kathy does all the admin stuff around that.
So I would encourage you, there's a couple of studies that I put references to on slide 14 that give some good references. So work by Jonathan Kaufman and Jamila Hussain and Sabrina Bajwa and others looking at that. So have a look in those papers for more work. But I know that there's lots of work ongoing that will be coming out in the next few years on this.
Thank you. I think this person, Shuang Jin, actually mentioned earlier that they used to be your student, Joe. Does that name ring any bell?
Yeah.
He said to say hello, and it was good to see you. But he said in a question later on he's really interested in the heat map showing that Chinese men and women had different patterns, where rich men were more likely to die in hospital, but rich women weren't. I missed the title of the work. Can I find it on the internet? In China, where palliative care is very limited, people with a lot of resources are likely to die in hospitals, but badly. But in the UK, it also happens. It may be a cultural thing. Do you have any knowledge on that study, Joe? Put you on the spot.
I've put the link to that study in the chat.
Brilliant.
Yeah, I mean, I think this is the thing with this kind of research. It does probably raise more questions than it answers, but these questions we wouldn't be able to ask if we didn't have this kind of indication of where the inequality is. So I think, we don't know why that is the case, and I don't think anybody is doing any research to look at that, but it highlights a potential area for future work that's needed to really understand why that is the case.
Absolutely. And this is where I would, with my qual hat on, is that you need to do some qualitative research to find out why. The issue. Absolutely. But that, I appreciate that can be very difficult, and that can be very difficult in different cultures as well. Hevie Cook has asked, in a country that poverty is rampant and low income are the ones, and people on low incomes are the ones most affected, what's your alternative practices to start this kind of services to be more accessible to them? This is from somebody in the Philippines. I'm not 100% clear on the question. Did you follow that, Joe?
Yeah, I've got it in front of me. I think what we've been better at in palliative and end-of-life care is doing research that kind of measures the problem, and we're really only starting to look at the kind of services and interventions that might be useful for addressing poverty and inequality in palliative and end-of-life care. So really, we don't know what kind of models of care would be better. But if we look to the literature on the wider social determinants of health and all the work that Michael Marmot and people have done, the thing that they point to is proportionate universalism. And that's where you take a universalist approach in terms of providing services for everybody, but you recognise that some groups might need more resources or different resources, and you try to deliver those resources in an equitable way. And what that looks like will be different in different places, but it's really important that we do consider that in all of the services that we design and deliver.
Thank you, Jo. Just to say, Kathy's come on and said that she can share the slides alongside the video on the task force page, so people will have access to the slides, Jo. Thank you.
Okay.
There's a question from Emma Baldwin. I think I've seen later on that she's had to leave, but I think it's probably worth asking the question. Can you suggest any particular specific outcome measures to measure impact more objectively at a smaller local level in relation to health inequalities and inequity?
Now that raises a really interesting question about outcome measures more generally. So, we can think about what are the most appropriate outcome measures in palliative and end-of-life care, like the palliative care outcome scale, for example. But we need to be really careful that those outcome measures have been validated in different ethnic groups, in different cultural groups, in different social class groups. And like a lot of research, those validation studies tend to be done in dominant groups who tend to be the kind of better off people in society. So there's a question about validating outcome measures, I think, in different minoritized groups. And I know that there is work going on in our department to look at that in more detail. So I don't know if we can say which are the most appropriate. It sort of depends what you're looking at. But I would, raise a bit of a question over, it's important to understand whether those measures are validated for use in the groups that you're interested in.
Thank you, Jo. We've got it might be more of a comment from Roland from Austria, who says, even in Austria, we struggle with inequality and poverty in the field of palliative care, despite having one of the best healthcare systems in the world. Disadvantaged individuals still fall through the social safety net and face financial difficulties. Every person living in Austria has the fundamental right to palliative care, yet inequalities persist, particularly concerning different religious beliefs and cultural backgrounds, an issue.
Yeah, I mean, I think that's a really good point. And I, when I was talking about the work that Michael Marmot had done, and he's looked at inequalities across the EU and found that in Nordic countries where wealth is kind of more equally distributed, health inequalities tend to be narrower, but they still exist. And it's really important to kind of look within countries, but also between countries, and even in countries, like the UK and Austria, where healthcare and palliative and end-of-life care is free at the point of access, you will still see inequalities. And that's because health inequalities are driven not by healthcare, but by all of those wider social determinants and those structural factors as well around education, employment, housing, wealth inequality. So it's a pattern that we see across the world, but it isn't inevitable. And the fact that it is different in different places indicates that it's not inevitable, and it doesn't always have to be as wide as it is.
Fantastic. Thank you, Jo. I've got a question for you myself, actually. I was just really taken with you talked about how in one of the studies that you did, that housing deprivation, I think it was in cancer patients, doesn't impact upon death in hospital. Now, you did then go on and sort of say that there are, there might be more nuances to that. But I mean, I would say that certainly in the team I work in, that's one of the biggest problems is housing. Housing in London is such a huge problem for people. But one of the other reasons that housing can impact on people's ability to die at home is that we can't get carers to go into properties that they don't consider to be safe as well, because that becomes the carer's work environment. I just wondered if you wanted to just expand upon that, because that really struck me.
Yeah, thanks, Steve. I mean, there's lots of other research as well, thinking about the Dying in the Margins project that's been led by Naomi Richards in Glasgow, and also Lorraine Hansford's work and Kelly Stadger's work that has really highlighted that housing is such an important issue. And I think, we would just all know that instinctively, that housing where you live is so important to every aspect of your life. It's fundamental. And certainly in the wider literature on social determinants of health, housing has critical importance on respiratory health, on cardio health, on life expectancy. So we included it in that model exactly for that reason, because there's existing evidence out there that says that it probably is an important explanatory factor that explains why people who live in more deprived areas are more likely to die in hospital. We didn't find an association in that sample, in that data set, and there are just so many reasons why that might be the case. The way that we actually measured housing in the data set is quite limited. It's to do with overcrowding, it's to do with whether you live in a flat compared to a house. It's a kind of combination of different items. But there are loads of things around kind of housing quality, or even kind of level of crime and safety in an area that we're not tapping with that measure. So I think we need to look at that again. These kind of studies where you're testing moderators and mediators, they can only ever kind of offer you one piece of the puzzle. You need to kind of build that work, and really that study and one other study that I did as part of my PhD are the only studies where we've used that approach in palliative and end of life care. And so it's tiny, really, the body of evidence, and we need to build on that body of evidence using different data sets, using data sets that are designed, specifically to understand the impact of housing. So, for example, we could use mortality follow-back surveys that ask detailed information about housing to try to unpick that and understand it in a bit more detail. So yeah, it's a big caveat from that work, and I'm glad you've raised it as a question, because what you don't want is for people to take away from that study and say, well, housing just isn't important then. We know it's just one study, it offers one bit of insight that we need to build on.
Absolutely, thank you. It just really stood out for me. So I think we're drawing towards the end now. There's no more questions in the chat. I mean, there's been some really insightful questions. I want to, on behalf of the EAPC though, Joe, thank you so much for the work that you're doing, and thanks for coming along today and talking about your work. And it's really great that people will be able to have access to your work as well. Kathy has just said, thank you to everyone for your engagement in the webinar. Please take a few moments to complete the webinar evaluation form and download the certificate, which you can do by just clicking on the link in the chat. Kathy, did you have anything else you wanted to say? People have started to say thank you to you, Joe, as well. Just from my perspective, hopefully we'll see some of you in Helsinki at EAPC later in the month. I think you're going to be there, Joe, aren't you? So if anybody is coming along, I'm sure introduce yourself to Joe and thank her for today and ask any questions. And just to say, from the EAPC Social Work Task Force, if anybody would like to join, they'd be very welcome. They can just contact Kathy at EAPC. And to say that in Helsinki, there will be a social work meeting. It's on Friday, the 30th of May, so on the Friday at 8 o'clock in the morning. And Audrey, who is the other co-chair, will be doing talking for a few minutes on following on from Joe's talk on the social determinants of health, and just thinking about how we can work together across Europe and beyond around this issue. So somebody said, Nasser says, see you in Helsinki. So some people are coming, Joe. So so thanks ever so much for today. Kathy, did you want to say anything?
Just thank you so much, Joanna. That was a really, really interesting session. Thank you, Stephen, for, as always, the Social Work Task Force do excellent webinars. So I'd encourage you, again, follow us on social media. You'll get to learn of new webinars coming up. Join us in Helsinki. It'd be great to see you all on Friday morning. And yeah, stay in touch, and hopefully everybody got that link to the certificate as well. The video will be going up within the next week or so, just depending on, there's a few sort of urgent things as a head office we're sorting at the moment ahead of Helsinki, but we'll try to get it up as soon as possible for everyone.
Thank you, Kathy, and yeah, hopefully see everybody in Helsinki.
Thank you. Take care.
Take care.
Bye bye.
Thank you. Bye. Kathy, did you want us to stay on or not?